Hello and welcome to MedTutor's lecture series. Our lectures give tips to medical students, house officers, and young practitioners on common conditions they may encounter in exams and practice, with an overall aim of improving the quality of healthcare delivery. We will talk on shock and its management. Shock is a serious life-threatening condition, and it is defined as the clinical manifestation of the failure of cellular function due to inadequate tissue perfusion and consequent cellular hypoxia, resulting from a reduction in the effective circulating blood volume. Shock may be classified as hypovolemic shock, cardiogenic shock, septic shock, neurogenic shock, and anaphylactic shock. In hypovolemic shock, there is reduction in the actual blood volume, which may be hemorrhagic or non-hemorrhagic in case where there is loss of plasma or extracellular fluid, as occurs in burns, intestinal obstruction, diarrhea, peritonitis, and vomiting. In cardiogenic shock, there is impaired cardiac function with reduction in cardiac output and effective circulating blood volume. It may be due to myocardial infarction, cardiomyopathies, cardiac contusions, valvular dysfunctions, cardiac tamponade. The other forms of shock, that is the septic, neurogenic, anaphylactic, are also known as distributive shock. They result from peripheral vasodilatation and pooling of blood, resulting in reduction in the effective circulating blood volume. The pathophysiology of shock. At the cellular level, cellular hypoxia leads to decrease in ATP production, 3 ATPs rather than 38, resulting in decrease in efficacy of sodium-potassium pump, with leakage of potassium out of the cell and movement of sodium into the cells, along with water, and the cells swell. Lysosomal enzymes and proteases are released, which causes lysis of cells and cause inflammatory responses. 25% of the total blood volume must normally be lost before hemorrhagic shock appears. For descriptive purpose, shock is divided into 3 stages: the early stage, middle, and the late stage. The early and the middle are termed compensated shock. The late stage is termed decompensated shock. With blood loss, there is stimulation of the baroreceptors, which in turn sends stimuli to the medulla via the vagus and the glossopharyngeal nerves. These stimuli are inhibitory stimulus to cardioinhibitory center, which in turn increase the activity of the heart, increasing the heart rate and force of contraction. Also to the vasomotor center or the cardioaccelerator center, which increases sympathetic outflow via adrenaline to increase heart rate and cause peripheral vasoconstriction. The overall effects of the baroreceptors is to increase vasoconstriction, increase venous return, increase heart rate and contraction, and bronchial relaxation. In the middle stage, with continued bleeding or inadequate resuscitation, there is diversion of blood from the peripheral and splanchnic circulation to vital organs, that is, the heart and the brain. Reduction of renal perfusion leads to release of renin from the juxtaglomerular cells, which causes conversion of angiotensinogen to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 in the epithelium of the lungs. Angiotensin 2 in turn causes vasoconstriction, release of aldosterone, which causes reabsorption of sodium and water, release of antidiuretic hormone, stimulates test center, stimulates sympathetic outflow. The late stage of shock, also termed decompensated shock. Compensatory mechanisms break down and circulation fails, with further blood loss causes reduction in coronary and cerebral perfusion. There is cardiac dysfunction, venous pooling of blood, and capillary damage from back pressure. There is impaired cerebral function resulting in confusion, restlessness, with progression to irreversible shock, coma, and death. Shock presents with rapid, weak, and steady pulse, low and or unrecordable blood pressure. The skin, mucous membrane are cold and clammy except in distributive shock, where the skin is warm. The mucous membrane is pale. There is rapid and deep respiration termed air hunger. Patient is confused, restless, apathetic, with blurred vision. There is decreased urine output or anuria, severe thirst, subnormal temperature, and patients may have multiple organ dysfunction syndrome. In resuscitation of patients in shock, control external bleeding by pressure packing, limb elevation, or other means for securing hemostasis. Elevate the foot of the bed to improve venous return. Fluid replacement is achieved by securing intravenous access using wide bore cannulae. You can take samples immediately for hemogram, grouping and cross-matching urea electrolyte and creatinine. Commence crystalloids, which are readily available. You can administer normal saline or Ringer's lactate 1 liter in up to 30 to 45 minutes. You reassess the patient, the pulse rate of the patient, the blood pressure, urine output, central venous pressure. If still deranged, repeat fluid administration. Repeat fluids up to 4 liters. After giving up to 4 liters and patient is not responding in a non-hemorrhagic shock, one may consider septic shock. For blood administration, in severe blood loss, crystalloid shows only transient improvements. Blood is cross-matched and transfused. Occasionally, uncross-matched blood may be given to save life. In the absence of blood, blood substitute such as colloids may be used, like the human albumin, which is most physiologic, fresh frozen plasma, hemacil, gelofuscin, among others. Oxygen supplementation is given. Partial pressure of oxygen is maintained between 80 to 100 millimeters of mercury. Partial pressure of oxygen below 60 millimeters of mercury and that of carbon dioxide above 45 millimeters of mercury will require ventilatory support. The use of drugs. Analgesics are administered. If patient is in pain, one may give morphine intravenous, 10 milligrams. Vasodilators may be administered to relax vascular smooth muscle and reduce systemic peripheral resistance. This will allow for improved forward flow, which improves cardiac output. The indications of use of vasodilators in the treatment of shock. After adequate fluid therapy and patient remains hypotensive with normal central venous pressure, but perfusion still remains inadequate. The drugs commonly used are dobutamine or dopamine. Patients being resuscitated are usually categorized into three: those who respond to treatment, those who respond and relapse, and those who do not respond to treatment. The second and the third category may require surgery to control bleeding. Monitoring during resuscitation. Patient is monitored clinically for the level of sensorium, the skin for warmth and venous refill, the pink conjunctiva, capillary refill. Urine output should be more than 30 mL per hour. Pulse rate and blood pressure is examined every 15 minutes. The central venous pressure is maintained between 10 to 15 centimeters of water. The lungs is frequently auscultated to avoid fluid overload. Arterial blood gases is also monitored. It should be noted that successful outcome will depend on early recognition, aggressive resuscitation, adequate monitoring. However, if patient progresses to irreversible shock, death is almost inevitable. Thank you for watching, and don't forget to hit the like button, subscribe and share for updates